and just wanted to welcome you to the virtual University of Surrey. I'm Professor Jill Mayburn, Professor of Health Services Research and Nursing, and I lead with Kath Taylor, who's on the call today, the Workforce Organisation and Wellbeing Group, and this project has sat within that. We've got a really exciting programme for you this morning and some brilliant guest speakers. And we're going to present our unprofessional behaviours guide. So when we talk about unprofessional behaviours, we're talking about unprofessional behaviours between staff in the NHS, not staff on patients or patients on staff, just for clarification. And we have developed this guide and a new website, and that's what we're launching and sharing today. So Justin, without further ado, if you could start sharing the slides, and I will introduce the team. Hopefully everybody can see the slides. So project team was quite wide and indeed international. So from the University of Surrey, as I say, I was the project lead. This is an NIHR funded study and was a realist review over 2 years, which Justin will explain. Justin Avery Oranger was the research fellow. I'll give everyone a wave, Justin. You're going to hear from him in a moment. He's going to share a lot about the guide. Ruth Abrams is a realist expert and contributed to the study. Ruth's here somewhere, so wave, Ruth. From the University of Leeds, we've got Judy Wright, who's our information specialist and helped us enormously with all the searching. University of Hull, we've got Mark Pearson, who's also a realist methods expert. University of Plymouth, Aled Jones, a subject expert and has evaluated the Freedom to Speak Up Guardians in a previous study. University of Birmingham, we've got Russell Mannion, who's done a lot. I'm sure many of you will know Russell and his work on culture and speaking up, so on. And from all the way from Sydney, very late at night today, from Macquarie University, we've got Professor Joanna Westbrook, who is an intervention expert, but has also done a lot of work around this work in terms of unprofessional behaviours and implemented the Ethos programme in Australia. So any particular questions about Ethos, we might defer to Joanna. So thank you for joining us so late in the evening, Joanna. So I'm now going to hand over to Justin, who's going to talk you through the agenda, what we're doing today, and then go on to the guide. So over to you, Justin.
Thank you, Jill. So this morning we will give a welcome and an introduction to the guide, which is what I will be presenting. During this, please, we do have a Q&A, which will hopefully work, in which you can upvote each other's questions, etc. And so during this, if you have any questions, please do post them in the Q&A. We then have 3 speakers from 10:45 to 11:45. Hopefully they'll all be able to attend, although one might be apparently trapped in an airport. So we will see. Hopefully they will show up. And if not, we have some words we can say on their behalf. We'll then address the Q&A. Hopefully have a break from 11:30 till 11:40. And from 11:40 till 12:10, we have the privilege of Fiona Kilpatrick from NHS Leicester, Leicestershire and Rutland Integrated Care Body, who will present a bit about our Active Bystander Programme. And then finally, we'll have some final comments and close. So, as Jill has already mentioned, unprofessional behaviours, as we are talking about them today, are those between staff, any interpersonal behaviour by staff that causes distress or harm to other staff in the healthcare workplace. Of course, these have been shown to impact patient safety as well as staff well-being, and we will explore a little bit more about that on the following slides. Today, we'll be presenting some of our findings as well as bits of the guidance from the guide, which come from, of course, this NIHR-funded realist review on the topic. So in terms of background, staff unfortunately experience harassment, bullying, and abuse quite frequently in the NHS.
Justin, yes, hold on one second. We've got a few people raising their hands in the audience. So I don't know if there's an issue with people seeing or hearing. I just want to check. Let me... Danuta, do you want to unmute and speak? Can somebody let us know?
I think it's okay if all the panelists can hear us, hopefully. But if you do have
quite a few hands going up, that's all. I just wanted to make sure everyone can hear us, Justin.
Okay. I think
Okay.
If you can't hear us, please post in the Q&A.
Yeah.
Otherwise, I will continue. I think perhaps people are thinking they put up their hands to ask a question. This should be in a separate Q&A box. Unfortunately, if you've joined as an attendee, you're not able to speak verbally or for us to see your camera without us promoting you, which we might be doing later on in the Q&A session if you want to ask questions verbally. So we will be able to do that later.
People confirming they can hear. So that's great. Thank you, everyone.
Thank you. So as the slide shows, unfortunately in the NHS, unprofessional behaviours are quite rampant, and they haven't really changed year to year. So 19% of staff report unprofessional behaviours from their colleagues, and 11% also originating with managers. And unfortunately, in people from ethnic minority backgrounds, also women, and people who identify as LGBTQ+, for example, or people with disability also experience unprofessional behaviours to a greater extent. So, for example, in the NHS staff survey, I think this is specifically on the workforce race equality standard data, 23% of white respondents report harassment, bullying, or abuse from colleagues, whereas 28% of people from Black or minority ethnic backgrounds do. And this is unfortunately an under-researched and under-addressed area. So some background behind this research, we were aware there's quite a few activities ongoing in the NHS to try to address these behaviours, including, I'm sure, one that Fiona will share with us later, but unfortunately they're not too well understood in general. And we wanted to look more globally to see what were the activities going on to address this issue. And also next to that, we also wanted to understand more about how unprofessional behaviours come about, and then how do the various things that cause or contribute to unprofessional behaviours interact to make the situation worse. So we'll give you a little bit of background about that today as well. So now a little bit about the academic background. Hopefully this will still be interesting to you. So we drew on 148 sources, bits of literature essentially. We also looked at grey literature like organizational reports from healthcare settings similar to the UK. And then when it came to understanding interventions or programs that are implemented to try to reduce unprofessional behaviours, we increased the scope of our literature and included reports from the whole world. And so that included 42 reports of these interventions. We then drew these findings together to try and understand how, when, why, and what situations these interventions may work. And we wanted to highlight now that these findings have been peer-reviewed, so they have undergone scrutiny from academic colleagues and found to be of publishable quality. So a little bit about realist methods. What is a realist review? So as some of you may know, oftentimes academics can do a systematic review to really try and see what is a certain intervention or program effective in terms of, does it reduce unprofessional behaviours, for example. The realist review, it tried to look a bit wider than that, not only at is it effective, but also how and why it may be effective and what aspects of its context might affect its success. So in this context, we have a little cartoon on the right. It says, to illustrate this point, if you implement the same program in 2 different locations, the same intervention, for example, it might be training about awareness of unprofessional behaviours. It might work in one situation, but not in another. And we try to understand why that is the case. So towards the end of the presentation, our website is live. We're not telling you the link yet because that would be a spoiler, but towards the end of the presentation, we will show you the link and you'll be able to download the guide. And it's in the same style as these slides. And if any of you are in the academic sphere, you can also cite it using this citation. And I believe we will share the slides and the recording afterwards as well to all who signed up on Eventbrite. So in terms of the scope of the guidance, it gives a brief overview of what the contributors to unprofessional behaviours are that we identified in our research. It gives some general points to be aware of when addressing unprofessional behaviours. It gives an insight into what are the strategies that have been used by different people to address unprofessional behaviours. It then gives a case study of the ethos intervention, which was evaluated and inspired by Joanna, who's here in the team, and has now been shown to be quite effective and is one of the interventions with the most evidence behind it in the academic literature. We then give some tips and tricks on how to build an intervention in a robust way. We've designed the guide to have both a focus on quick wins, so things that you might be able to do if you don't have too many resources, as well as longer term things you could be doing if you're a person, for example, who are higher up in the NHS organizations who might have more resources at their disposal. And lastly, we have some key principles to consider that are perhaps under addressed in the literature, things that have two sides to them that are quite interesting and important to consider when designing an intervention. So in terms of the contributors to unprofessional behavior, we found that on the left here, the general environments that contribute to unprofessional behavior might be those of workplace disempowerment. So for example, people who are working towards the bottom of a hierarchy, such as new entrants to a workplace, they can tend to be disempowered and therefore less able to speak up and more susceptible to unprofessional behaviors. There's also a lot of harmful workplace processes and cultures, for example, types of leadership that can lead to unprofessional behaviors being more likely, as well as bureaucratic elements, for example, that can promote frustration that can then lead to unprofessional behaviors occurring. There's also the problem of inhibited social cohesion. So for example, these days, there's a lot of bank staff or people who work in shifts and they're unable to build the relationships with their colleagues that would be necessary to have the sense of support in the workplace. And then these factors can also all combine to reduce people's ability to speak up and report when unprofessional behaviors are happening, which then means that managers are not able to address these behaviors or roll out programs to tackle them because they don't know where they're happening. So these can all work through increasing likelihood for staff to engage in unprofessional behaviors directly. They can also reduce the ability for staff to cope with the unprofessional behaviors, which worsens the impact on their well-being. And they can also have reduced ability, as already mentioned, to challenge, report, or address these unprofessional behaviors as they're occurring. And this, of course, can then lead to reduced patient safety when you're working in an environment with unprofessional behaviors that are rampant. People become distracted, they're not able to communicate well, they're not able to report medical errors, and this all leads to the impact on patient safety. It then also impacts well-being negatively, and patients can then have a poor experience of care quality and safety. So you may have noticed already that I've been talking both about interventions and strategies. So we want to also make clear what we're talking about with respect to both of these things. So at least in the academic sphere, interventions are generally the whole program that you're using to address unprofessional behaviors. So this might be strategies themselves, which I'll talk about in a moment, as well as the means through which they're delivered. So it might be in a lecture, it might be through written form, it might be a poster, for example, or it might be different psychological techniques like in therapy or mediation, for example. And typically it can also be evaluation methods. So however you want to understand whether it's generating an improvement or not. And strategies are also the things we try to really pull out and into our guides to give you some tools to address these unprofessional behaviors. And the strategies are really the active ingredients, the behavior change strategies that sit within an intervention. And these can be, for example, strategies to reduce conflict through conflict management training. It might be assertiveness training. It might be environmental modification, so putting up posters to try and help people change behaviors. But usually these would be one part of an intervention, and interventions would draw on multiple strategies together. So during our research, we found that there's 5 major types of intervention that is currently being used to address unprofessional behaviors. These can be single session interventions. So it might be a one-off lecture. These generally were found to not be as effective as other types of intervention. It could be multiple sessions. So these are just, for example, it might be the same sessions that run over multiple times over a longer period. These might be a little bit more effective than the single sessions, but not incredibly effective. We also found that there are interventions that rely on sessions, but then have something more, such as rolling out a new code of conduct for staff, for example, to follow. And then lastly, we had two quite organization-wide and complex interventions that we'll talk about a bit more in the following slides. So these were professional accountability programs, such as Ethos that Joanna helped roll out, and then also, for example, structured culture change programs. And we'll talk about these a little bit more now. So in the guide, you'll find that these do not feature these 5 types, but what we've done in the guide is collapse them a little bit more to make them a bit more simplified. So we've simplified session-based interventions, those 3 types of session-based interventions, into quick wins that you might be able to do with fewer resources. And then these longer term and more resource-intensive interventions, we've collapsed into the longer term interventions. So you'll see throughout the guide, we've got things to address both of these areas. And of course, we also want to highlight that just because people have done certain things so far doesn't mean that's the totality of what can ever exist. There's a lot of things that could be done in the future, a lot of strategies you could imagine to try to reduce unprofessional behaviors that have currently not yet been used. The research here is generally at quite an early stage. There's a lot more to be done. And we also want to highlight that throughout this, please keep in mind that it's important to generally do something to address unprofessional behaviors. And doing something is always better than doing nothing. And a lot of times you can be doing something quick while also developing something in the background that will be longer term and more effective in the long run. So these longer term interventions, unfortunately, all sort of stem from the US because they have a lot more resources there, I guess, and are a bit further ahead in tackling this issue. So the first type, the structured culture change intervention type that we want to highlight, is called CREW. This stems from the Veterans Health Administration, which is a very large organization that delivers healthcare to US military veterans in the US. It's called Civility, Respect, and Engagement in the Workforce, or CREW, as I already mentioned. And in this intervention, they really emphasize responsiveness. So it's typically organization-wide. They have a lot of different units within the organization, and they try to understand what's causing unprofessional behaviors within those different units using a survey that they have at the beginning. They then schedule time out far in advance to focus on addressing unprofessional behaviors. And of course, that then makes sure that it's on everyone's agenda. And then they have a flexible range of different strategies they can deliver depending on what's causing those unprofessional behaviors in those units that would allow them to tackle the root causes, or at least that's the aim. And there are some evaluations of these in the academic literature to date, which show that it does have some level of effectiveness. But of course, you need very high level engagement, and you need a lot of resources to be able to implement this. Similarly, there's another type of intervention we identified that's longer term. These are called professional accountability programs. And these also stem from the US. One is from the Vanderbilt group, which is also a large group of medical organizations in the US. And they typically have a system of escalating professional accountability, it's called. So if you see on the graph here, the graphic along the bottom, for single incidents of unprofessional behavior, they'll have informal conversations with people. Oftentimes this uses peer messengers and a reporting system. So both Ethos and Vanderbilt have a sort of organization-wide reporting system where colleagues can report incidences of unprofessional behaviors. And that will then be reviewed by triage people who have an oversight of the reporting system. And then they can, depending on the situation, if there's a pattern of unprofessional behavior, or if it's a one-off event, or if it's a severe unprofessional behavior, they can then take different actions. And alongside that, there's also typically some kind of training as well. For example, training on how to use the system, as well as assertiveness training. So I'll be now presenting a little bit about the Ethos intervention. Please, feel free to keep posting any questions. We do have Joanna here with us, who is responsible for rolling out this program and evaluating it in Australia. So it'd be a great time to pick her brain about anything to do with this intervention as well. So Since 2017, this has been implemented in 8 hospitals throughout Australia. It's a very wide-scale intervention as well, similar to the previous one. The aim has been to foster positive culture change, to reduce unprofessional behaviours and improve people's ability to speak up about medical errors, to improve patient safety, as well as about unprofessional behaviours. So this uses an online reporting system that allows people to speak up anonymously, to hopefully help them feel more safe when doing so. It then relies on the aforementioned peer messengers. And importantly, in its reporting system also enables people to report positive behaviors, which is good and helps people get both motivation from the system as well as to address unprofessional behaviors. And there's also training, assertiveness training, I believe, as well, that's rolled out, and training on the systems itself of the intervention. This has covered both clinical and non-clinical staff. And Joanna and colleagues have recently published, or are publishing, a paper that identifies some of its findings. And they've also published papers around the experiences of the peer messengers, for example. So please, do look up this program if you're interested. So they found, I've sort of color-coded here according to the graph and the text. So you can see here on this graph that over those years, they've actually found that the amount of staff who reported never experiencing bullying has increased from 6.4% to 11.8%. And the number of staff reporting experiencing these unprofessional behaviors weekly to multiple times daily has fallen from 41.7% to 35.5%. So that's quite an improvement over that period of time. And likewise, staff experiences of 5 extreme types of unprofessional behaviors, such as physical assault and demands for sexual favors, has also significantly declined. And so these are quite important learnings, we think, for the NHS, where we do have quite well integrated healthcare system. And it should be possible to roll out similar programs in the UK, but it's unclear why that isn't currently the case. So what strategies are available to you, and do they work? This is quite a complex question from an academic perspective. So I just want to highlight some of the issues with saying quite clearly which strategies work and which strategies do not work. So as I already mentioned before, a lot of interventions typically use several strategies and they're implemented in a particular context. And so it's very difficult to say that strategies will work independently of the other strategies that they're implemented with, or that they will work outside of that context in which they were evaluated initially. And so what we've done is we've laid out all the options that have been used. And at this time, we're unable to necessarily say which of them work very well. We can say interventions work. So for example, the ethos and the crew that we've just mentioned. However, for these individual strategies, we've presented these more as options that you could draw upon in your organization. And in the guide, we've also matched strategies, which I'll show you in the next slide, an example page, to the types of things you might be encountering in your organization. So you can hopefully select strategies to tackle those issues directly. So this is one of the examples pages from the guide, which you'll be able to download shortly. I'm sure you're all waiting eagerly for the website address. But so for example, if you want to tackle workplace disempowerment, and improve staff members' ability to cope and speak up, then we have a section, for example, then outlining strategies that may improve confidence for staff to come forward. This includes, for example, assertiveness training, role playing, cognitive rehearsal, and also encouraging staff members to keep records of different events that they've experienced that will improve their ability to be believed when they come forward. And also, for example, improving awareness and knowledge type strategies. So there's, I think, about 10 pages of strategies in the guide that you can have a look at and draw upon. We now want to outline some key principles that are important to consider when designing an intervention. So these are really patterns that we identified across interventions that can lead to them being more or less successful, and also areas that are perhaps under-addressed that really need to be addressed in future interventions to help improve their effectiveness. In the guide, we present these dynamics and then also some solutions that may work to address some of these dynamics. for both quick win type interventions as well as longer term solutions. So first, I want to highlight that so far interventions have very much focused on this notion of bad apples, that there's a few people in organizations that are behaving badly, and that is not a systemic problem. However, based on our research findings, what we found is oftentimes the things that are causing unprofessional behaviors are at a systemic or organizational level. And so just focusing on a few badly behaving individuals does not necessarily stop the systems that cause more behaviors to emerge that are bad. So in this sense, we want to encourage interventions that focus on fostering an environment that is psychologically safe over addressing individual conduct. And of course, like we've seen with the ethos intervention, it is important to address individual instances of behavior. We're not saying that that's not important. However, it's also important to bear in mind that if this issue is ever to be tackled, we need to tackle those contributing factors. Next, we want to highlight, and of course, Fiona, I think will talk to this as well with their Active Bystander program, that it is important for organizations to encourage staff members to intervene when they see behavior that they think isn't right. This sends a message that the organization is not tolerant of unprofessional behaviors, and that can be very important. However, we also found in the literature that others highlighted the risks of intervening in a culture that isn't safe, and that can cause reprisal to people. And also certain people will not feel able to step in, and that can also cause what is known as moral injury to staff, where they feel like they should have intervened, but they weren't able to. And as a result, they feel like essentially they've had a moral impact and they haven't acted in the way that they believe they should act for the type of person that they are. And so we want to make sure and highlight that encouraging intervention should happen, but only when safe. And we also want to highlight that a lot of interventions we think have not necessarily worked because they are in a situation where unprofessional behaviors have been experienced for a long period of time. Staff are often losing confidence in their management and their leaders to address this issue. And they want programs that are likely to be effective. And so in order to engage with these programs, they really need to see them as likely to work. And they also, on the other hand, need to make sure and see that staff at managerial levels, leaders are not themselves behaving in an unprofessional manner. Because what it's very important to do is to send a very coherent unprofessional behaviors not tolerated message. Staff need to see that the intervention is likely to work and it isn't just a tick box exercise. And only then will they be fully engaged with the intervention and able to come along in that culture change journey. And likewise, and related to this, managers also need to include themselves in an intervention when they're rolling it out. As we've seen in the NHS staff survey, and it's not exactly not known that managers themselves, unfortunately, can be interpreted to engage in unprofessional behaviors. As we've seen 11% in the NHS staff survey from 2022. It is important for this to be acknowledged and addressed by organizations in order for their interventions to be seen as fair and authentic, and for staff to then engage with them. And on this issue, we've seen, for example, that as highlighted in earlier slides, that unfortunately people from certain backgrounds, so Black minority ethnic staff, staff who identify as LGBTQ+, and also women and people with disability are actually the most impacted staff by unprofessional behaviors in particular. And so it's very important for this disproportionate impact to be addressed by interventions. We unfortunately only found one intervention out of 42 that was seeking to address any kind of racism, for example, or discrimination explicitly. None really addressed the plight of people with disability, and none addressed or mentioned LGBTQ+ people. And so we think it's really important for interventions going forward to acknowledge these discrepancies in experience and bring everyone along in the journey. But unfortunately, it's also difficult to do this because the literature also highlights that it's important for interventions to treat everyone equally and not to create rifts between different groups. So, for example, giving training to one group that doesn't receive, but then another group doesn't receive it, or for example, to point fingers at surgeons and not at including nurses in a program, for example. It's important to make sure that everyone is brought along in the journey equally, and to include means that help bring everyone along in future interventions. And as we've seen with the crew intervention, they have quite a responsive approach, they call it. So in different units, they'll do different things. And this can make it quite difficult to understand what worked and why. So on one hand, you might want to do the same intervention multiple times across different circumstances. This would make it easier to understand what works about it and what doesn't work about it. But on the other hand, you might want to vary the content of an intervention within your organization or on different times that it's run. This can help actually target the things that are causing unprofessional behaviors more specifically, but it might also make it more difficult to understand how or why it may have worked in these different contexts and what combination led to that result. And this is the last key dynamic to outline. We also wanted to highlight this as something very important to keep in mind when you're designing your interventions. Why are we reducing unprofessional behaviors? Of course, unprofessional behaviors are bad, but we think that interventions should be designed with the end goal in mind of improving patient safety and improving staff well-being. So it is possible to design interventions that result in unprofessional behaviors being reduced, but might also pit staff against each other and create an environment that is socially less nice than it was before, one could argue, perhaps by enabling people to report each other without any kind of triage system, for example. And so it's very important to keep in mind the impact that you might be having on staff well-being. And next to that, like we've seen with some online reporting systems, it's possible to, if not done correctly, to incentivize speaking up later without creating a psychologically safe environment. But actually creating a psychologically safe environment is very important to ensuring that people are able to report medical errors in the moments that they occur, which then can prevent harm to the patients. So we just want to highlight that keeping both of these end goals in mind is very important when thinking through how and why your intervention may be leading to its impact on unprofessional behaviors. So you also have 10 key points to keep in mind across all these types of interventions. Number one, it's very important to present clear messaging about reducing unprofessional behaviors, to send the message that they're not tolerated. It's important to assess organizational culture if you have the capacity to do so, to really understand what is it about our culture that's leading to these unprofessional behaviors. In general, using more strategies within an intervention or rolling out more interventions wider, if you have the resources, is more effective. It's also important to make sure that your intervention is not overly punitive, for example, that it doesn't lead straight to HR ramifications if someone behaves poorly. Like we've seen, we didn't present these data, but from the ethos intervention, for example, when people have informal conversations with potential instigators of unprofessional behavior, these are typically addressed most of the time without any need for further ramifications. Maximize the visibility of these activities you're doing to really capitalize on people engaging with it and seeing the effects that can help generate engagement. Encourage allyship with minoritized communities, of course, to help make sure that everyone is brought along in the journey. Identify and nurture leaders who are presenting the right behaviors. Harness existing organizational processes where possible, for example, professional development reviews, existing meetings, to really make sure that resources are maximized and that you're doing everything possible within the resources you have available. Involving staff in co-creating interventions and having input can really help staff feel engaged with the activities you're undertaking. And also having dedicated staff is quite important to make sure that interventions and activities are sustained, but at the same time, we've seen that turnover, for example, can lead to programs dying out, and it's very important to make sure that there's a succession plan for a lot of these activities you might be undertaking. So finally, just some I'll hand back to Jill soon for the website launch, but some areas to focus on in future interventions. We found that interventions are not very well articulated in terms of how and why they're supposed to work. We encourage people designing interventions to really think through why these particular strategies are going to lead to the particular outcomes that you desire, what are the assumptions about how and why this will work, and what are the contexts in which you're implementing these programs that might affect your success. It's very important to consider these three factors when you're rolling out these programs. Again, we want to highlight, of course, the undue burden on women, ethnic minority, disabled staff, as well as people from LGBTQ+ backgrounds. This impact needs to be acknowledged, and it needs to be incorporated into the core design of these interventions going forward. And lastly, we want to highlight the lack of research in the UK. We think there's a lot of good things going on in the NHS. I'm sure many of you attending are aware of such things, and we really want to encourage people to document these, to report their findings so that others can learn from it, and maybe set up networks to share learning in the future. So where can you get the guide? I'll turn back over to Jill now to talk to these final two slides.
Thank you very much, Justin. Thanks for that very comprehensive overview of our work. Just to reassure everyone, we've seen all the questions in the chat, and we will come to the Q&A session and address those properly. But where can you get the guide? Yes, today we're launching this new website. It's going to have several projects on here, and on here will be the recording of the webinar and the guide, and also a presentation that Justin gave at the Health Services Research Network conference in June. So we will continue to build these resources and add our published papers. So please go to that website. There is also a link to other work we've done, looking at the impact of COVID on nurses. And we've got another webinar coming in December, which will also be on the, we'll send out information, but looking at care under pressure to poor psychological wellbeing in nurses, midwives and paramedics, another National Institute of Health Research funded study. So here's the details of our funding award and our research protocol, and you will be sent these slides or have the information via the webinar. So thank you very much, Justin. So now is our time to invite our speakers in. So we have three distinguished speakers from different walks of life, but also to comment on our guide and what they've heard. And our first speaker, we're delighted to have the Right Honourable Rachael Maskell, MP for York Central. In July, Rachael introduced a bill to Parliament to provide for a statutory definition of bullying at work and to enable claims relating to workplace bullying to be considered by an employment tribunal. Really important. The bill also sought to provide for Respect at Work Code to set minimum standards for positive and respectful work environments, and we're delighted and honoured to have Rachael with us today to say a few words about our work and guide, and I'm sure about her work too. So over to you, Rachael. Thank you for joining us.
Thank you so much, and can I first of all say I think the guide is of such high quality and really recommend it, and trust that people will not just read it and put it on the shelf, but really engage with it. I think it's not only pragmatic in the way that it's trying to look at the issues which people are experiencing, but to put some of the frameworks in to, first of all, try and deter from those behaviours occurring in the first place, but then to really have a positive engagement around addressing them. And I think that's so important, because what we're trying to do is to create positive work environments, and often the engagements can be so negative that it creates another cycle of a negative culture where this behaviour can then be replicated. So I think it really tries to de-escalate that risk and to ensure that psychological safety environment is put at the forefront. And I do really congratulate all those that have worked on it for such a thoughtful approach to this, but nonetheless ensuring that safeguards are there and correction is put in place through education and, if necessary, through process. I guess the work that I've particularly been involved in is looking at the legal context and currently recognising, whilst there is legislation around discrimination at work, harassment at work, there isn't around bullying at work. And bullying itself is a very emotive word. I know the academic context is talking much more about negative behaviours and positive behaviours, but it is the context in which we're working. And in looking at that, first of all, we depend on the ACAS definition of bullying. Interestingly, that they changed their definition to say that it could be a single act, which again, you incorporate a single instance into the interventions that are then needed, which of course are lower key, but it can then escalate clearly into people who are vexatious individuals or individuals who perpetrate negative behaviour on a consistent basis and often on multiple individuals. So recognising the lack of a legal framework in this field, we need to establish, first of all, what bullying is in law, and therefore to adopt a legal definition as part of that. And that's certainly what my legislation seeks to achieve. But of course, if you then have knowledge, you need to know what you're going to do with that. And whilst all of these interventions are the right next step, once you've identified that behaviour to de-escalate risk, clearly not all employers, shall I say, are as enlightened, but also it can be a very difficult sphere for an individual, and therefore having that legal recourse to an employment tribunal is very important. At the moment, very few cases will come before any form of justice. Those that do, often it'll be through a constructive dismissal route where somebody, first of all, has to resign their job. That cannot be right. Or it comes through process of the Protection from Harassment Act. Again, was not designed for these purposes. So we do need bespoke legislation. And then looking at that legislation, ensuring that it is able to be responsive to the claims that are being made. Obviously, I do appreciate it's a difficult sphere, but in following through with the 6-month limitation that is applied to other forms of discrimination, harassment, being able to bring legislation forward. And I've been talking about it's the third leg of the stool around dealing with negative behaviours within our tribunal system. Obviously, with regards to the award that is provided for an individual, most people just want the behaviour to stop. They want to be understood as to have experienced a detriment, and if they can return to safe working, of course, but if that's not possible, to have that recognised as well for financial award. And the tribunal system is well versed in that. But in my legislation as well, I recognise that we need culture change. And I think your guide, whilst pertinent to the NHS, I think could be applied to any workplace at all. And I very much hope that it does have really broad scope and will certainly support that. But in looking at the wider landscape, first of all, we said that we want this to apply to all forms of employees, because often employees have the most protection at work, whereas workers less so, office holders very little. And of course, we have the new forms of bogus self-employed and irregular employment practices. And we would want to see this apply to all people who engage in that employment environment. We also want to create those positive behaviours within the legislation. And again, I think your guide could play a really significant role in talking about how we could engage with that process. So we've talked about a code, a positive behaviour code, so that individuals have understanding of what does that look like. And I think particularly what really stood out for me in your presentation today is talking about the importance of professional accountability, because obviously we know in a very highly pressured environment, which the NHS is, that time given to professional accountability has been very much squeezed. And of course, through that, conversations are held to understand the pressures and the stresses that individuals are experiencing, whether a perpetrator of negative behaviour or indeed a recipient. And certainly that can tease out the context and the environment to ensure that the employer takes responsibility to de-escalate those risks. And of course, understanding that context in a environment where people can speak up, and I'll come on to that in a moment, I think is incredibly empowering. And I would very much want to see that further embedded. Now, we know under things like Agenda for Change, clearly it was very much part of the package, But of course, that just isn't being delivered in an environment where people are literally running and not stopping. So we have got to say that this is fundamental to the safe delivery of services, and that putting those pauses for those conversations is part of creating a safe NHS for the future. And I think it's really important. We need to stress that. Some professions are very good at it. If we look at things like clinical psychology, very much built into the kind of professional ethos. Whereas if we look at many professions now, this conversation never occurs. So we've got to ensure that it does. And then, of course, you can embed some of those elements of agenda for change around development and well-being, and looking at you as a professional as well. I think the other thing to particularly draw out is ensuring psychological safety in the workplace. We know that at the moment in particular, but it's true in a high-risk environment, that individuals' psychological well-being is now put at risk, and we need to look at how we de-escalate that risk. So I think, again, looking at some of the tools you promote is going to be a really important part of that. Just to close, to say, in our framework, we're also looking at engaging with the EHRC. We've had advanced conversations with them about some of the roles they can play around inspecting workplaces. We think there should be proper organisational accountability in this sphere as well, because clearly within an organisation we try and do our best, but actually if we are working together as a cluster of organisations, we're more likely to get it right. And if we have got external oversight of that, then that can assist. So certainly if individuals report that things are not as they should be to EHRC, to have those powers which the body was set up to have, although funding cuts have reduced them, is important. For instance, the opportunity to come in and inspect, to report, and to then demand change, and to go through that process. Obviously, I just wanted to reflect, from Robert Francis's report, and obviously that was 10 years on, 10.5 years now, since he published his report, when looking at the culture of being able to speak up. And again, I think your guide is really good about talking about the empowerment of individuals and some of the training that could be available there. I was just looking at the report, and I raised it in the comments just this week, that 937 incidences of whistleblowing identified by the Office of the Speak Up Guardians have resulted in detriment to those people who have whistleblown. I think that highlights a lot to me today, to say, even though there is structure in place, it is about culture change, and it is about changing that ethos, being a listening organisation and engaging organisation. And I think the work that you have been able to put in, evidence-based, tested and tried, and also the tools that you have provided, will take us much further down that road than we've gone before. So I really just want to congratulate you on the work that you've done, and very much want to engage with you in the future.
Thank you so much, Rachel. That was a fantastic overview of the work you've been doing and the legal framework, and couldn't agree more with everything you say. I mean, it's quite shocking how whistleblowers are treated, and Aled and I on this call did some work on Freedom to Speak Up Guardians, and what was quite striking there is, and unexpected, they were introduced by Robert Francis, was that over half of cases raised were about bullying, and that was expected to be patient safety, and it was about bullying. So yeah, much work to do, but thank you so much for joining us. I know you might have to leave us shortly, but if you can stay for the Q&A, then that would be fantastic. But thanks for being here and for your words. I'm going to move on to our second speaker to reflect on what they've heard now. Felicia, I hope you're with us. I know Felicia's in transit. There she is. Might be joining us from an airport. There's a dedication for you. So I just want to introduce Felicia. She's Associate Director of Nursing at King's Hospital NHS Foundation Trust, and Chair of the Chief Nursing Officers and Chief Midwifery Officers for England Black Minority Ethnic Strategic Advisory Group at NHS England. Given these roles, we look forward to hearing Felicia's reflections on our work, specifically in relation to Black and minority ethnic staff in the NHS. Over to you, Felicia. Thank you for joining us.
Good morning, Jill. Can you hear me?
We can, thank you.
Thank you. Just checking you can hear me. So thank you for the presentation. I didn't hear all of it, but I've read through the guide. And just to start by saying, the same as my colleague previously, that the guide is very, very welcome. We know that we have a number of tools out there about addressing certain behaviours, but what I was particularly struck about the work is the evidence base that's used to underpin the work going forward. I specifically liked the professional, promoting the professional accountability pyramid, which was very clear and articulate. And the running and threading through the work is also around accountability. And I often think, Jill, that when we're talking about behaviours around bullying, harassment, protecting people's psychological safety, often we're not explicit about the language that are used to describe those horrible behaviours, and we don't teach that very well, especially in the junior levels of staff. Sometimes the language is used as very high level, and I was really struck about some of the clear and simplicity of the language, so that any level of staff who's exhibiting, who is receiving some of these behaviours can grab this guide, and it's really clear and it's explicitly simple. One of the things I was reflecting on just through the presentation was around the personal costs, and our previous speaker has talked about that. And often, just being at the board and within divisions, we talk about a lot of harms within the clinical and professional environment, but psychological safety is not always defined as a harm, and it's very explicit and ran through the guide here. And it struck me that when we are talking about harms in the clinical workspace, we often are thinking of physical detriments to our patients, but often we don't describe that in relation to our professionals and our staff. And the guide has really been explicit about labelling those, and that's something that I think we need to be taking back to our organisations around. This is just equivalent to an adverse incident as the normal KPIs and the clinical variables. The other thing that struck me through here is about some of the techniques and methods around addressing some of the professional behaviours, especially around the responsibilities of allies and bystanders. And that is really, really important, because it's the bystanders that kind of influence the culture, because some of these behaviours are really tolerated. And what we want is a lot more upstanders, but we also need to ensure that the people that are speaking up and speaking out, which is threaded through the guide, that they're protected. You will know that the Michelle Cox case that was been in the news earlier on this year in February, where Michelle took NHS England to an employment tribunal and won, that comes at a great personal cost, and we shouldn't underestimate that. And you've alluded to some of that within the guide around the whistleblowing ethos. So if I relate it, so I'm really thankful for the guide. I think for me, what stands out is the explicitness, but also the focus on action. Often when we're talking about some of these abnormal behaviours or oppressional behaviours, there's always the dialogue around the lessons learned. We must, learn the lessons so they are not repeated in the future, but they are. And what this guide is specifically focused on is the actions, and that's really what we need, is actions that can be measured, evaluated, and implemented. And I think that professional accountability period can be used to do just that thing around the measures, around improving. So what we put in place, okay then, so these are the outcome measures, this is what we said we were going to do, and this is the reflection and the deliveries against those KPIs. I think for me, as being the chair of the CNO and the CMIDO BME Strategic Advisory Group, I note your 28% figure at the beginning of the report around the bullying harassment for ethnic minority staff, Black and ethnic minority staff, and the ethnicity, and that's reflected in the NHS National Staff Survey. And we saw this, so part of my remit is to advise both the CN and CMIDO around the natures and the intelligence that comes through about their experience. And unprofessional behaviours is a key factor for people not progressing up their career structure and ladder, for having significant mental health and wellbeing problems. We know that the suicide rate amongst nursing professionals has increased. So it's really, this has come at a really good, I think, timely point to coincide with some of those national directions. And we know that it's important to get this right, because we are in the business of caring. And if we don't care for our professionals and address these behaviours, then how can they deliver a high standard of care? And we need to make sure that the patient is at the centre of some of this work. That's really what needs to underpin it. And I think the work also is a launch pad for when the NMC revise the code. I would like to see that this guide is submitted as a real influence in taking and identifying the specific behaviours in the upcoming revision of the NMC code. If I reflect back on just to close some of the arguments, the discussions around Black and minority ethnic staff, when we talk about unprofessional behaviours, we saw a lot of that in the pandemic. We saw people being marginalised, people being treated very differently. And I know this guide will address a lot of NHS organisations, but I think, as our previous colleague said, it can address and be a perfect application for the independent sector and the health and social care sector as well. And I think this guide really equips those staff that are traditionally marginalised to be articulate when they are defending themselves, to be articulate when they're putting board papers together, and be articulate when they are matching data to behaviours and outcomes. So I just really wanted to highlight some of those key issues.
Thank you so much, Felicia. Thank you. Thank you for joining us in tricky circumstances, and thank you for your fantastic reflections. I think you've raised some really important points. Glad the guide spoke to you, and really, really pleasing to hear that it might empower individual staff members as well as encourage organisations and managers to do something about this. So thank you very much. I hope you can stay for a little while and and help us answer some of those maybe. Thank you. Thank you. So I'm going to move us along now to our third speaker, who is Stephen Weeks. Stephen is policy lead at NHS Employers and leads on work related to the NHS staff survey, and so is familiar with the long-standing issues related to bullying and harassment within the NHS that is measured in the survey. He also has a brief to ensure employers are aware of the latest research evidence in this field, so we look forward to hearing his thoughts on our work and guide. Thank you, Stephen. Over to you. Stephen.
Hi, thanks very much.
Yep, you're unmuted now.
Thank you very much. And I just want to say, in terms of the panelists, I'd very much echo the points made by the previous panelists. You introduced us all as distinguished speakers. I certainly don't feel as distinguished as either of the two previous panelists. But I do work in this area for NHS employers. But I just want to defer to the expertise of the previous two panelists, and also to say I'm very pleased on a virtual platform again. Rachael, in my earlier part of my career, I was a staff side representative and trade union official within NHS trade union, and I actually worked with Rachael in an early part of that career. So I'm pleased to be on a platform there. And in terms of Felicia's contribution, we very much try and support the work of the individual NHS organisations that really felt Felicia brought this issue alive in terms of the actual impact it does have on colleagues who experience these behaviours. But just in terms of the formalities, NHS Employers is an advisory body for NHS organisations, just to clarify that. It might come up in the question and answers, supporting them to improve employment practice in a range of fields, including in this one. And as you also mentioned, I represent NHS Employers on the NHS Staff Survey Advisory Group, where the issue of bullying, harassment, and more broadly civility, respect, and unprofessional behaviours has been an issue identified in the survey for many years, and I'm sure we can get into that in the discussion. But just in terms of the guide itself, I really do welcome the guide. We've, through the staff survey and other sources, had a lot of research evidence about the scale of these type of behaviours in the service. I don't think we've had as much evidence on the interventions that might help to resolve it. I think this is a real step forward in terms of giving employers evidence-based interventions that can help them address these issues. And I know there are other people on this call who've been working with employers, including Roger Klein. And I think there is a desire amongst employers. Obviously, I can't speak about individually every employer in the NHS. There's over 300 employing organisations, over 1 million employees. But overall, we are committed to addressing this issue, and employers are working particularly with their staff side organisations to address this issue at local and national level. And there's a renewed emphasis on it at the moment, and to have an evidence-based research that looks at what can be done in the most effective way is really, really helpful. I'm sure we'll get into more detail in the discussion about the various issues that are raised, but I really wanted to emphasise that an evidence-based intervention is a real help to employer practitioners in the service to address these issues, and there's a renewed commitment to do so. And finally, just to say that there is actually a range of employers taking action on this, and although the national staff survey results, I agree with Justin, haven't moved substantially, one or two of them have actually improved a little bit over the last 5 years. There are NHS organisations that have made significant progress in this area, and it's important, I think, to share learning from those to encourage positive action by as many employers as possible, and also to continue the focus at national level, including possibly refreshing our overall national frameworks around this over the next period. Thanks very much.
Brilliant. Thank you so much, Stephen, and really delighted to have you with us, and thanks for those thoughts and reflections. Really, really useful, and we're looking to work with all colleagues on this call and on the webinar to take this guide forward. I mean, as researchers, we really want our work to be used and to be practically used and to influence policy and practice. So please get in touch and keep these conversations open. Roger, I hate to put you on the spot, but given Stephen's comment there, I didn't know if you would be willing to say anything. We haven't prepared you for this, so completely. Roger was a member of our stakeholder group, just to know everyone that he knows the work and he knows us. So Roger, I don't know if you want to say a few words before we move on to the Q&A. I'm just allowing you to talk, I think. Oops. Is that working? Where's Roger? Anyone else can help me by unmuting Roger? I think I've done it, but are you able to speak now, Roger?
Roger, if you're here, you should be able to unmute yourself now and be able to talk. But I think you have to unmute yourself.
Yep. I don't think we can unmute you. Ask to unmute.
He's still muted.
Yeah, perhaps Roger's not able to speak at the moment. So Roger, will come back to you, and sorry for putting you on the spot.
Apologies for volunteering you, Roger, there, but if anyone wants to look up his work, it's freely available on the internet, and I would strongly recommend it.
Yes, Roger is really huge in this area and has done a lot around Black and minority ethnic workers' rights and work. So Roger, welcome, and let us know if you are able to speak in a moment. So we've got a Q&A now. I know somebody's asked for Rachel's stats, but I think Graham Martin has provided the stats about the whistleblowers from the Freedom to Speak Up Guardian, so hopefully that answers that question. We've got quite a few questions in the Q&A, just going back to some that we've sort of answered, but one was around, so Tom Marshall has asked about ethos, and Joanna, I don't know if you're able to answer that, but it's from the methodological perspective, the data presented are single data points, pre and post intervention, not at all robust. Was this just a summary, or are there more details on this, e.g. interrupted time series data showing a step change? Don't know if you want to speak to that.
Sure. So very briefly, maybe just to give you some context, the Ethos program, which was rolled out across 8 hospitals, across Australia, and we were involved, my team was involved in undertaking a comprehensive evaluation over 5 years. So in essence, I absolutely agree with you. One pre-post survey isn't the complete answer. There were several different elements to the evaluation to try to understand whether any sort of cultural change had occurred. There are several papers outlining different aspects of the evaluation. We undertook a very large survey at baseline to try to understand what were the actual behaviours people were experiencing in these hospitals. And then we came back 2.5 and 3 years later to look at whether people's experiences of unprofessional behaviours had actually changed. And we did, while Justin was only able to provide one little result, which were percentages, we actually did a lot of modelling results to look at adjusted odds ratios, etc. So there is a lot more detail there. But equally, there was a lot of work done to look at qualitatively, how did people experience the system? And so there's a very recent paper where we interviewed over 30 middle managers in great detail to try to understand what is the experience of middle managers who actually have to operationalise this program, what impact did it have for them. As Justin mentioned, we did a survey of the messengers who had to deliver these messages to people about those initial incidents of unprofessional behaviour to see how did they feel about that. And really these messages are about trying to nip these behaviours in the bud to get people to reflect. And so our results, which actually did show after a couple of years that there was this significant reduction in unprofessional behaviours, and it was consistent across these. We did 5 hospitals. They're very geographically located in different areas. They're very different management styles. So that gave us some promise that these programs seem to be making a difference. These results are sort of consistent with what they found in Vanderbilt in the US, where they found that when people did receive these reflection messages, those individuals, about 70% of them, never appeared again in the reporting system. So there is really, with these types of large organisational change programs.
Is it just me or have we lost Joanna? No, it's not just me. We've lost Joanna. The Sydney link has disappeared for now. Sorry, Joanna, we've lost you for the moment, but thank you for that very fulsome answer. We've got some general comments to the panel as a whole. So the dynamic between creating this is from Emma Skipsey, dynamic between creating a psychologically safe workspace and worker detriment following whistleblowing. What are the panel's thoughts? Don't know if anyone wants to tackle that one, Rachel or Felicia, or one of us could have a go, but wanted to give our Rachel or Felicia or Stephen an opportunity to say something about that if they'd like to.
Sorry, Jill, I didn't catch the question.
Oh, sorry. The dynamic between creating psychologically safe workspaces and worker detriment follow whistleblowing. What are the panel's thoughts?
That is such a challenging question. I don't think many organisations get that right, because I think that it calls into question the own organisation's vulnerabilities around not protecting staff. So there are some examples where some organisations do a good practice, but it's not. I think the statutes are there. The framework is there, but in reality, the whole ethos around unprofessional behaviours is because, it does really call on people to do some really deep self-examination about their biases and why they behave the way that they do. And I think that if boards could really grab onto this in a really forthright manner, it kind of sets the tone for the organisations, so that when people are speaking up and speaking out, that's the norm, that when people raise those concerns, they are believed until proven otherwise, and then the board and then the middle managers and the senior leaders are behind that particular person and they back them up until proven otherwise. It's so costly for the person involved. It comes at a real personal cost, and some people have to make the decision and have the courage to either do that knowing there's a cost, or do that knowing that even if they lose, they'd still raise the issue anyway. So I think, and that's why the guide is good. I think you need 2 approaches. You need social some social revolution from the ground floor. And then I think the organisation's responsibility is to set the tone and to stand by those people. But it's very, 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 we see that in the news all the time. Doctors, nurses and other people, they are strung out to dry when they whistleblow. And what I'd like to see is a lot more really great case studies where people have been able to do that and that the organisations back them the whole way. You know, I don't think we've got it right at all, but I think there are some green shoots.
Great, thank you, Felicia. Thank you. And yeah, we've seen many cases of that, haven't we? And definitely in our work through the pandemic, many who went to the media were silenced or told to be quiet. And certainly any whistleblowing is very much stamped on. Rachel, I'll come to you. And Roger, I see you're with us, so I will come to you very shortly. Thank you for.
Two things, if I may, Jill.
Oh, okay, yeah. Could I just go to Rachel first, Roger, and then come to you? Thank you. Thank you.
I always go to Rachel first.
Apologies.
Good to hear you, Roger. Yeah, I mean, I just want to say leadership is really key in this arena, and I think there's lots of areas that we need to look at, particularly if we're looking at kind of the issues around disempowerment of people with protected characteristics. We absolutely have to change the leadership dynamic there and ensure that we've got more diversity within our leadership in the NHS. It's absolutely fundamental to this. But also we need to ensure that leaders take the time to undergo significant training to examine their own cultures. And I think that's something that, again, time is not given to that. But that if you get the leadership and stuff at the top right, then that will filter down. It's not just the very top tier, it's that kind of middle management, the people which are really under pressure as well. And that little investment, if we think about the scale of what we're talking about and the scale of detriment people are experiencing, that little bit of investment will really pay dividends. So we've got to try and embed that into part of the leadership model now within the NHS. It really would pay off.
Thank you, Rachel. Thank you. Yeah, really important points there. And I noticed there was another question earlier asking whether we'd engage with the King's Fund Leadership Programme. And I don't know if you were particularly referring to the Compassionate Leadership Programme, but yes, we have. And we had a member of our stakeholder group from the King's Fund. So definitely, thank you. Roger, can I bring you in now and then I'll come to Stephen? Roger, please join us. You might be able to turn your camera on now. No?
I can't see my camera here.
Don't worry.
I could be eating a sandwich while I'm speaking.
You could.
So Rachel's pitched a couple of my best lines.
Sorry about that.
But actually, some of what she said is very relevant to what's been happening this morning, which colleagues may not be aware of. So the traditional NHS response, and you can see it, for example, in the response to the Lucy Letby case, has been we need more policies, procedures and training, but we don't address the sorts of issues that Rachel and other colleagues have been talking about. And I mean, the first person I think that set it out really neatly for me was Megan Wrights in that BMJ piece where she talks about leaders have to stop thinking that if you put whistleblowing helplines and all sorts of other things in place, that will crack it. I'm not against any of those, but if the leadership don't model and demonstrate and lead and give permission for the behaviours that we need, it won't happen. And the reason I mentioned what's happened this morning, Rachel may be aware, Stephen Barclay has written to every NHS organisation to tell them that they must not appoint any EDI posts anymore. And the effect of that, I have to say, I've got now 9 chief execs who've sent me private messages. There's clearly a reaction happening, but the effect of that will be that the issues that Felicia raised, and which we're in about next month we'll be publishing a report on, which is why one group who are particularly wary of speaking up are BME colleagues. It's going to make it harder for them. We did, as some colleagues will know, we did a big survey. We got 1,300 responses. It matched, correlated with what tribunals have been finding about the challenges that BME colleagues find in speaking up. So the kind of what you're doing is coming at a really good time, but actually it's going to bump into a situation where the group that find it hardest to speak out are going to think it's going to be even harder. Might be something the Health Select Committee might want to look at. Steve, you'll see Steve Barclay's letter. I mean, it's just culture wars in the NHS, but I do think it makes your stuff more relevant, but it also makes it more of a challenge to bring it about.
Thank you, Roger, and thank you for all the work you do in this area. So important, and I'm glad the chief executives are talking to you. But yeah, very challenging times, and such a detrimental backward step, one would argue.
I mean, just to cheer people up, two chief execs are so angry about it, they've gone online saying they're going to carry on doing what they're doing. So we'll see where that goes.
Well, good for them. But yes, may have consequences. Stephen, can I bring you in now?
Thanks. I'll resist the temptation to comment on that. I'm speaking on behalf of NHS employers rather than the personal capacity. But I'm sure Roger could guess my personal opinion about that. Please don't anybody quote me on that. I'm sure NHS employers will be responding in due course. The point I wanted to raise was about the response to whistleblowing. NHS employers does not comment on any individual whistleblowing cases, and I'm really going to be very careful about what I say next. There have been a number of very high-profile whistleblowing cases in a number of different trusts in different areas of the country in the last month or so. I would say a response by a large trust in the West Midlands is perhaps the one I would encourage employers to have, rather than a response by a specialist trust in the Northwest. People can look up their cases in the Health Service Journal. How a trust responds to issues that are raised to it does send a really strong message about how it actually in practice deals with these issues. I'll just say that. And secondly, in terms of protection for whistleblowers, there have been some steps at national level, working with colleagues in NHS England, to give greater protection to those people that do take the very brave step of whistleblowing. But obviously that's dealing with the issue after it's happened, and we shouldn't really be in that position of having to protect the position of people that are adversely affected by whistleblowing. But just to let people know, there have been some steps to try and ensure that the detriment suffered by whistleblowers doesn't affect, well, will affect, that it doesn't have as severe an effect on their career opportunities as perhaps has been in the past. But I wouldn't say that the way that the NHS has responded to whistleblowing is something that can be really that proud of up till now, but there is an attempt to change that. And I think there are some trusts now that do respond in a very different way than historically has been the case to whistleblowing.
Thank you, Stephen. Thank you. So many questions now. I will try and get through them. Felicia, there's a specific question for you about getting my trust to adopt the anti-racist pledge from Paul J. I'll put this alongside it. Could you send me any data on how and what is being done to tackle this? I'll leave you, Felicia, to answer that in the Q&A. If you open the Q&A, you can see it was 1104 question. Perhaps you could answer that live. How can the work support the Freedom to Speak Up guardians? I hope that the work we've done would help support that role very much, enable you to have evidence to provide to board and evidence to suggest different interventions that might work and that the board may wish to adopt, hoping it gives you a treasure trove of things to speak to and raise. And what's the role of professional health regulators in this? I don't know if anybody wants to tackle that one. Stephen.
Well, I think Felicia did mention about the role of the individual bodies that regulate particular professions, and there is an ongoing debate about the Nursing and Midwifery Council professional regulatory framework. But I think I'll just mention also the inspection regime within the NHS itself, which is not doesn't apply to individual professionals but applies to organisations. There have been some significant but small steps forward, I think, in terms of how the Care Quality Commission, which inspects all organisations within the NHS, addresses these issues. And they have, particularly some more recent reports, looked at the issue of bullying, harassment in particular, and generally civility and respect as part of their overall assessment of whether an organisation is well led. And that people in the service will appreciate, that does actually concentrate the minds of boards quite significantly. And although I'd much prefer we dealt with this on a positive basis, I think the fact that the inspection regime is citing this as an indicator of whether an organisation is well led is pushing out the overall management agenda as well. I mean, hopefully we are talking to the Care Quality Commission about addressing this in a more positive way within there.
I'm Dr. Justin Unger, and today I'll be presenting to you the findings.
Oh, Justin, what's happening there?
Never mind.
That was Roger, sorry. I'm muted. You, Roger, sorry.
Yeah, so there is being given a clearer and more central focus within the overall assessment of the inspection regime within the NHS. And I think we'd be hopeful that work would continue. And perhaps perhaps the evidence base from these interventions could be taken into account as part of that.
Certainly. Well, any ideas of where and who we should send our guide and our evidence and the recording of this webinar, including CQC and others, please let us know. We'd be very happy to engage with everyone. A question about neurodiversity impacts on the findings of this guide, allied to protected characteristics, and frequently find that colleagues with neurodiversity struggle to adapt to differing cultures and other divergence. Absolutely. I think this is another equality, diversity, inclusion question. Hopefully relates to some of the other issues we've heard addressed. We know there's particular challenges for that group as there are for others. And we want it to be a safe culture for everyone, but that's some of the challenges. I don't know if anybody else wants to comment on neurodiversity in the team. Justin?
I think it's a very under-researched area. Having been through all the literature, is not something that's mentioned, but I imagine it plays a very key role in this. And so I think it's definitely something we need to look into in the future.
Thank you. And rather similar for the next question from Tenju, I'm interested in how silent kind of racism be addressed, which might not be obvious at that time. Obviously, that's quite challenging. That's perhaps where allyship and bystanders can help, or allies. We didn't find much about interventions. I mean, we did look at microaggressions particularly. But Justin, I don't know if you've got anything to say about that.
Just a reflection that we did try and produce a sort of typology of different unprofessional behaviors, actually, which we didn't put in the guide, but perhaps now upon reflection might have been a good idea to have put in there. And we do highlight in that typology that certain types of unprofessional behaviors can be less visible. Of course, discrimination is often not done face to face, but it emerges through processes and systems. And so from that perspective, these are important unprofessional behaviors that are less visible, but nonetheless, and hard to measure as well, but nonetheless need to be tackled.
Thank you. Thank you. Thank you for the thoughts on sharing the webinar with the National Guardian's Office, CEO and NHS England. Thank you. We will do so. There were some previous questions that we definitely tried to answer about how was staff wellbeing measured. Justin, I don't know if you have any thoughts or comments on that, or Joanna, we could bring you back in. Now you've rejoined us. We lost you for a moment there, about how it's measured in ethos. I'm imagining it's often not explicitly measured, but is measured in staff surveys. But I guess then we've got issues of confounding and what's affected that. Did you see anything specific in the literature, Justin, that we could speak to that?
I'll let Joanna come in first and then.
Okay.
So with the ethos program, no, we haven't done anything explicitly in terms of measuring, staff well-being after ethos. Certainly, we measured the impact in the initial baseline. We asked about unprofessional behaviours. We asked about the impact that it had on their own well-being, about the impact on quality and safety and teamwork, and certainly a high proportion of staff reported that it did have an impact, and certainly there's lots of evidence about the impact on well-being, but the extent to which interventions are effective in improving well-being, there is less known about that.
Thank you. Thank you.
I think it's very oftentimes in these health organizations, you have many different things going on at once, and it's very difficult to separate the impact of the unprofessional behaviors intervention from the other improvement in QI initiatives that may be ongoing. So I think connecting up that causal chain will be something that happens in the coming decades, I suspect.
Thank you. And Justin, thank you for your answer to the question, working in HR, what can we do to increase confidence in staff? I would also encourage any of you to read Amy Edmondson's work about how to create a learning organisation where you want to hear the challenges and the difficulties, but easier said than done. But Justin said we've got quite a number of things in the guide about improving confidence to come forward. But yeah, generally we need culture change and begin to feel it's safe enough to speak up without detriment. And that's one of the problems, isn't it? Okay, I'm just looking through the questions. Do we have any other thoughts and questions? Have we involved the occupational health community in our work? And regarding the comment about neurodiversity may be worth further research. I absolutely agree with that. I'm sure that's true. We didn't specifically look at that, and as Justin said, there was very little in the literature, and if you remember, this was a literature review. We're looking to try and take forward more research to try and implement some elements of the guide and evaluate that, and work with some case study organisations in the NHS to see what they're doing and to sort of map. But that has not yet even been written, that grant, let alone funded. It takes a while, so we're working on that. Stephen, do come in.
Just in that context, it is referenced in the guide, but there has been existing work with quite a large number of organisations through the work of, by NHS England on the Civility and Respect Toolkit and associated programmes to do with culture and leadership within the NHS. So there is already existing network of organisations taking action around this, and there is an existing resource which I think this piece of work can build on and complement around promoting civility and respect within the NHS. This was produced by colleagues at NHS England and has been disseminated over the past 2 years. I don't want to mention the pandemic in this context, but I think it probably would have spread further and been had more of a focus if we hadn't had the pandemic that came out just before the pandemic hit.
We have signposted that in the guide as well. So we have a link in there to the Civility and Respect program, and we're very interested as well in to what extent NHS organisations have been making use of that. So if anyone wants to contact us with that information, we'd also appreciate that. I
can share that. I know it's not massive numbers, but it is a significant number of trusts have been doing work around that or integrating that in existing work they've already been doing.
Great.
Thank you, and thank you, Felicia, to alerting me that you can't access the Q&A. My apologies. I'm learning how the webinar works, but we might need to promote you to co-host or something to enable you to do that, to answer that question if you still have time. So wanted to thank all our panelists and the Q&A so far. This webinar is not over yet. We've got much still to hear. We've got Fiona Kilpatrick coming, but we were just going to have a short comfort break now, and I just want to take this opportunity to thank our speakers, thank Justin and all of the team for the work that we've managed to put together. I hope you've enjoyed it thus far. Thank Rachel for joining us and all her work she's taking forward in Parliament. We watch with interest and hope the bullying bill gets several more readings and passed. And Stephen, but please stay with us if you can. This is not a goodbye, but it's just a thank you for now, and also to Felicia, who's joined us in the most challenging circumstances. So very, really grateful. But please stay with us and listen to Fiona's presentation, which is about the Active Bystander programme. So we're looking forward to that. But a short comfort break now, and then we'll come back. Thank you.
It's 11:40. We will come back. Thank you.
Sorry, 11:40. Thank you. Just 10 minutes. Do you want to? There we go. Restart the recording. Perfect. So welcome back, everyone. We're delighted to have so many of you remain with us to hear our next speaker. So now we have Fiona Kilpatrick, who's going to speak to us, and she's going to tell us about the Active Bystander Programme. Fiona works at Leicester, Leicestershire and Rutland ICB, and will tell us more about how the Active Bystander Programme was developed, perhaps some of the challenges she's faced, and plans for the future of the programme. So over to you, Fiona, and we're delighted you could join us. Unfortunately, our speakers have all sent apologies, so Stephen and Rachel and Felicia have had to go, but I'm sure they will view the recording, and we'll make sure I send it to them. So over to you.
That's fantastic. Thank you so much, Jill, and Justin, thank you as well. As is the way so often, it was serendipity that I linked in with Justin and found out about the focus groups for this guide. and really think it's a great guide and is going to be really useful. And I will be sharing it with our active bystanders in our futures page and our community of practice. So I'll share, host disabled participant screen sharing. So I was going to say I'll share my screen.
Justin, do you know how to fix this? Or you, I think, Fiona, have you sent us your slides? Perhaps Justin could share them if we can't fix this. Apologies, everyone. Let's see.
Video co-host, that's the most I can do, I think. I don't know if that will hopefully
Does that
allow
work?
you to share.
Yes, and so I will, I share my screen then, Justin, just to double check, and then I'll be able to go into my...
I hope so. You can,
Okay.
I think you can choose to share your whole screen or your presentation.
I will, let me share the whole screen just so that there's no hiccup. Okay, cool.
Great, thank you.
Okay.
I can see that.
Yep.
Correct.
There we go.
And I'll set it up there.
Perfect. Yeah, you can see that really well. Thank you, Fiona.
Thanks so much for having me here today. It's really good to tell you about our programme. As I mentioned, I think the guide is really helpful, very practical, and follows through on some of the sort of premises or the things that we wanted to achieve when we started out as well. So really quite practical. So my background is transformation, quality improvement, and I'm an OD specialist in civility, respect and violence prevention. And I'll tell you a little bit about how we developed our Active Bystander programme. It was a pilot summary. So we were really looking to, in 2021, as a result of our staff survey results, our head of EDI at the time at the University Hospitals of Leicester and our OD systems and leadership director had both started to talk about what was happening for our staff and our workforce in general. And we were looking at this across our whole integrated care system. So emergency services workers, our NHS staff working at the acute trust, NHS staff working at the mental health trust, voluntary sector colleagues, as well as other colleagues who are working in our health and care family, if you like, of workforce across Leicester, Leicestershire and Rutland. They started to hold some town hall events and asked people what their experiences were. And they were really quite saddened to find that it was about 250 or so colleagues that were spoken to in that time had either experienced or witnessed bullying and harassment at some point while they were at work. And they really did want to change this. So the idea was a proactive organisational culture approach to address these harmful behaviours that people were experiencing. And what they were hearing is people didn't always know they'd witnessed something. They didn't know if it was a problem or not. They weren't quite sure how to intervene. And it was just having the tools and techniques. And that was for all different grades or bands, if you like, in the NHS. And across different roles, the clinical, administrative support, there was a real golden thread through all of this that people were experiencing. So we wanted to model a compassionate culture and also kind of make real change. So having that information with us, and also, and this is, I guess, building a bit on what Roger Klein and others have mentioned this morning about some of the messaging that's coming out at the moment. We have a really positive approach and support from our leadership. So our senior leadership, our Chief People Officer for the ICB, has specifically emailed us to tell us, and will be speaking to us again later this week, about how they do value our EDI colleagues and the work that we do, because this is absolutely the foundation for our being able to achieve our long-term workforce plans about recruitment, retention, making Leicester, Leicestershire and Rutland the best place to work, and for patient safety, for the people and the populations that we serve to have the best care, and patient safety being at the heart of that is also about looking after our workforce and people feeling able to speak up, removing some of those barriers to speaking up. Our aim was really simple, which was really just to create an active bystander programme. Sounds simple, but turned out to be a bit more complex. So just having a quick look at our priorities, and I will share the slides later on so you can see them properly, with the sharing screen not being ideal the way we've done it. We fit together our active bystander program, and this is again where it's tricky sometimes to evaluate discrete programs, but we've embedded it as part of our wider equality, diversity and inclusion work. So it fits alongside things like reverse mentoring, our inclusive decision-making framework that we use, our staff network works, looking towards how we also have our systems leadership piece linking in with that, how we collaborate to improve care, using coaching, mentoring, buddying, all those aspects, holding it as a web, if you like, for the wider impact longer term. We initially got our senior leaders together from across our integrated care system. So the acute trust, our ICB leaders, and all those senior leaders signed up to, if you like, our program of work. And we then worked with internal sponsors. So this is a bit of the how. We've got leads within each of our organisations, and that's including the county and city council colleagues for our health and care colleagues, to actually be internal sponsors. So we brought them together to begin with weekly while we were setting this up last year, and getting everything together. When I came in post, one of the challenges, I'd say, is funding. So we were very lucky. We got some seed funding from the National Civility and Respect team, and quite a lot of support from them for that initial setting up, having me released from my role so I could do a secondment to pick this up and really focus on this work, pulling together the material, going out and getting people engaged, energized, enthused about the project itself as well. And that is often a challenge, because our challenge will continue to be there in terms of how we continue to fund the post, if you like, the position, to be able to focus on this until it becomes embedded as the way we do things around here. So a lot of my first couple of months were spent looking for funding, and we were very lucky that we did draw some more funding down from different pots and different places, and that our ICB have absolutely supported us in this rollout, if you like. So our program consists of 4 elements. There's the actual active bystander training, which I'll tell you about in a minute. Senior leadership development, which we've heard a couple of times today, in terms of creating that psychologically safe space. What will happen when I speak up? What will the impact be on me? Is there any detriment to me? Or observing the role modelling of behaviours, that gap between the rhetoric of our values and behaviours on the wall and the reality of what we see some of our senior leaders or middle management line managers, when they walk in the floor, what people see will happen. So our senior leadership development was around looking at psychological safety, understanding what that is, removing the barriers to speaking up, and that's work that's still ongoing now. We haven't quite got there yet. And what we did learn, though, was we hadn't necessarily specifically looked at what the impact would be for line managers. So we have a line managers webinar session now specifically as well for line managers of active bystanders that come on our program, that we can help them support their active bystanders well. So that concept of looking after your active bystander once they've spoken up, and then feeling safe to fail, because sometimes you might intervene and it does not work out the way that you expected, so that they know that they are safe, and this is the Amy Edmondson piece, safe to fail, but also that they'll be learning in that process. We have a train the trainer program that we're testing out as well to have more people on the ground, if you like, able to embed it within each of the organisations that are involved. And we have had evaluation embedded in this from the start. Our challenge, and this is how I'd got hold of Justin in the first place, was funding for an evaluation. It was very difficult for us as a program at the outset to get funding to be objectively evaluated, if you like. We have throughout kept, and I'll show you a little bit of our evaluation, tried to evaluate what we're doing. Some quantitative, mostly qualitative, but some quantitative, where we've looked at the moral courage, professional moral courage survey, where we get a baseline, and then we try to return to that later on to see if people feel more confident to intervene and de-escalate situations. So a very practical program. Our content is for a day and a half of face-to-face training. We understand it's almost a pyramid, if you like. So at the top of that pyramid, you'll have only a few people across our very big workforce, about 60 to 70,000 people across the system. We'll never get to train everybody in the same way. So we'll have our active bystander champions, if you like. We went where the energy was first, the people who were really keen to work in this area and help be allies, help intervene and de-escalate from a positive perspective. So the positive, calling people in, not calling them out, because when we call them in, we're able to invite people to learn, to share stories. People are more likely to change then as well and change their behaviour. So that theme kind of popped up earlier on in our talk as well when I was listening. So it was about looking at that wide spectrum of from micro incivilities across to overt prejudice and discrimination, and understanding what the drivers for those unacceptable behaviours might be, and identifying or name that behaviour. I wasn't quite sure what I saw, but having followed the programme through, people then are able to say, actually, that was a micro incivility. I understand that. I also have a sense of what to do next. It's also understanding the damage that happens when others don't intervene, particularly for BAME colleagues who look around and see that nobody else, the colleagues that they work well with, have not intervened when something's happened. And we work through that in that day and a half as well, in terms of understanding why other people might not be intervening and why we might feel morally obliged, but also with the skills to intervene, de-escalate, and role model the behaviour that we want to see. And then we also deal with very practical strategies. In the half day, we do a learning by doing. So that half day session from the day and a half is really very practical. We have a couple of scenarios that we filmed, real life scenarios, which we then work through so that people actually have the chance to test out using different language, test out and intervening, so it doesn't feel quite so difficult a leap to do. Underpinning all of this, again, back to the psychologically safe piece, is we talk a lot about how and when to intervene, and it's only when it's psychologically safe to do so, or physically safe to do so. And we talk to people about, in using the strategies, that delay or delegate are absolutely the right things to do when you can't directly intervene in a situation in the moment. And it's thinking then about how you would follow through, because policies and processes we know are not enough. How you then follow through with speaking to the right people, influencing in the right way to make that change a reality. So following that day and a half, we then have 90 minutes action learning sets once a month for 5 months. The idea there is that people go out into the field, if you like, wherever they're working, and they will come back with what's happened and then share their learning. So sometimes things will go great and they'll say, this is the strategy I used, this is what happened, and the others can learn from this in their group. Or it could be, I tried this out and it didn't work. This is happening, what might I do differently? And the group then learns together. By the end of that 5 months, though, we don't just leave them alone, if you like, to go off and be active bystanders. We have monthly coffee catch-ups, again, 90 minutes. Interesting for us is that despite all the clinical challenges, we started in October last year, and then the pilot finished in February. We had a lot of interest, and people still made the time to attend because they felt it was too important not to. They felt that this changed their working environment enough for them to want to continue coming. They needed to invest that time, and they were being released for that time as well by their line managers. Just a brief overview of some of the reasons why, because we were interested why our active bystanders wanted to be on this programme. And for many, it was about those positive things, wanting to promote EDI, wanting to promote compassionate cultures, creating a positive work environment. quite a few people wanted to understand why. Why are people behaving like this? And what can we do to change that? Number also for personal development, thinking about their leadership and wanting to increase their confidence and to share learning and good practice across the region. And many had been personally affected by the unacceptable behaviours that had happened in their area. Some of the feedback from our delegates has been really positive, and this is it's been word of mouth. We've not had a full communications package, if you like. It literally has been word of mouth, people telling us about the programme or telling others about the programme, their line managers then wanting to send more of their staff on the programme as well. We have a questionnaire, so we have some of our evaluation has been a moral courage questionnaire where we had a baseline, and we were hoping to follow up at 3 and 6 months. The challenge has been that by the time you get to 3 and 6 months, it is quite difficult to get those questionnaires back. We do a learning questionnaire on the areas that we focus on, so the drivers of inappropriate behaviour, through to how do you know to intervene, or what do you feel more confident. And we've seen an increase in that pre and post knowledge average, if you like, for those particular areas that we focus on. And we have also, those are small numbers at the minute, we've increased that over time with following the pilot. But also the self-assessed confidence to intervene has also increased. And that is when it's physically and psychologically safe to do so. People do feel that there's been a difference. A lot of the delegates have said that there's the impact of the learning has been a big theme, has been about that stepping back, pausing and reflecting, and now being more mindful of how to create a safe space for colleagues, an inclusive space, which has been really important as well. And interesting for us because we have had a number of very senior colleagues through to the whole gambit of colleagues in the same environment together, learning together. And we've also had a greater awareness of people's own micro-incivilities. So we're very keen to start the programme on understanding self. So with that positive regard for others, seeking to understand first, there had to be something about starting with self. And so we do focus on that quite a bit. And we've had consultants who've turned around. One of them came to us and said, the reason I joined this program was because I'm having some issues with my consultant colleagues, and I wanted to get myself genned up so that I was able to intervene and basically tell them what I think. She came out of it saying, gosh, micro-incivilities, I've just had a mirror shown to me, and I've had some learning here that's been really helpful for me to go back into the situation and have conversations, uncomfortable conversations, but be able to start de-escalating some of the situations that I was observing and part of. In terms of our action learning sets, that has been really valuable. People have reported that they really felt, despite that increased pressure and witnessing and identifying more of those negative behaviours, they have felt that they've been able to do something about that, a little bit of ownership, also the ability to make things feel more positive for them and to reflect on their own experiences again and learning for others. Very quickly, our internal sponsors have really been amazing. They've helped us keep integrated across our different organisations. So we have one language that we want to share. And with our pilot workshops being a success, we're now a bit oversubscribed. So between now and March, where our ICB are funding us to continue, we are oversubscribed, and we have a waiting list of people who want to come on the programme, which is brilliant. And we are thinking about what next, how to do more. Our content from band 2 through to band 8B, well, actually it's more than that now. We've had chief people officers come on our programme as well. It's been validated in some way, because I, to begin with, wasn't sure how we pitched it when we had a room full of 12 to 20 people, completely different backgrounds. Diversity was really key, that it resonated with everyone, and we found that it has, and that was one of our USPs as well. And we have, I'll hopefully, if we've got some time, show our video of our community of practice that we've established in the last year. So very quickly, we're going to keep evaluating. We would put a plea out, though, if there are any official evaluations that we could get that are objective, that would be brilliant. We need to get a comms package in place. Our leaders module on psychological safety is really key, and we're working on that still. We have had some train the trainer work. We're looking at a Midlands scale up with Midlands colleagues, particularly Nottingham and Derby, our neighbouring ICSs as well. Considering the national scale up, we've been in conversation with our National Civility and Respect team, who, due to the restructuring, though, there'll be some challenges as to where that might fit, how that might look, and looking at the barriers to speaking up. But despite all that, our attendance has been good. We've had very low dropout for the usual types of programs like this that might run over winter pressures. And we will continue with our action learning sets, continue supporting our coffee catch-ups and line manager webinars. Do you think, Justin and Jill, we have time for the video?
Yes, by all means. How long is it?
It's about 8 minutes.
Yes, by all means.
I can pop it in the chat.
No, do show it. You had until 12:10 on our schedule, so perfect timing. Do go ahead. I'm sure everyone would like to see the video. Thank you.
Okay. If you bear with me.
Oh, sure. Thank you very much for that comprehensive presentation. We've got a few questions in the chat, which I'll bring to you afterwards.
Brilliant. I'm just going to bring that up now.
Great.
I'm sharing the sound because that is something, even on Teams, which I work with all the time, I'm not the best at. So please do let me know if it's not sharing the sound. Are you able to see everything?
I can see it, but I'm not hearing anything.
So there won't be any sound for this first slide, and then there should be.
Yes, we can hear that. Thank you.
I'm really pleased to be here today to celebrate everything that is Active Bystander. For me, Active Bystander isn't just an intervention, a one-off, that's it, we've done it. This is the start of a social movement, a start of a new way of supporting our staff. The NHS at 75 years old has now got a plan that talks about attracting, retaining and supporting our staff. And really the Active Bystander programme is about how do we feel that we want to come to work? How do we feel we've got the skills to bring our whole selves and really change the culture within our organisations? And what's really special for me about LLR is that this isn't just about the NHS. This is true integration across health and social care, and really delighted that Ruth Lake has co-sponsored this as a director within the local authorities to make this as important across all parts of our system. And I want to recognise that doing new ways of working, behaving in a different way is not always easy. But with the skills from Active Bystander, it's the right thing to do.
When I read about the Active Bystander programme, I just thought this sounds fantastic, very real, very relevant issues that a lot of us have to deal with in the workplace. The themes that they deal with really helps you to self-reflect. They talk about micro incivilities, even things that perhaps we're not even aware of. You know, it makes you look at your behaviour as well as everyone else's and how best to kind of handle things positively.
When I joined the programme, I had no idea what an Active Bystander was. Didn't really understand any of it. So the very first session that we have, when they started at the beginning talking about microaggressions, I immediately thought, oh, I understand this. It was really inspirational, and I thought there's so many people in our workplace who this can benefit.
Got involved in an Active Bystander programme because I wanted to learn and improve. There has been an improvement in our work environment. In fact, this morning, one of my colleagues was saying how the morale has improved in the department because we are tackling historic behaviour.
I wanted to learn and I wanted to grow, and I think if you're involved, then I can help others getting involved and help my team and just make it a better working environment.
it's absolutely reinforced what I already believed, and it's given me the confidence to know that there are other people around the system that are feeling exactly the same way as me. If I'm going to do something, I like to do it well and do it properly. And this programme just seemed absolutely ideal, and it was, actually.
It was almost invigorating, just having all this information that you could take away and help you deal with situations.
People were either experiencing bullying, harassment, victimisation, or had witnessed it and done nothing about it. So the Active Bystander programme helps us address this, creating the right culture where all people belong.
This journey has actually proven that having interventions, tools, resources to help staff deal with inappropriate behaviour, language, attitudes, really makes a big difference.
The key thing for me has been the passion and commitment and the sheer drive of all our active bystanders to create a community of practice together, so that it's something that we can make a huge difference of, each of us incrementally doing a little bit each day to make things a whole lot better in the bigger picture.
I think the standout for me with the programme was the interactivity, a little bit of role play. Some of the videos that we saw really made it come alive.
We could all say exactly what we thought, open up, show vulnerabilities, cutting through all the barriers. I learned a lot. I love the real life stories. It just encouraged really open and frank discussions, sometimes uncomfortable, but I think it needs to be sometimes to move forward.
If I'm sending an email, for example, I will think of the impact of the way I'm saying it. Oh, actually, maybe I shouldn't have said it that way, mate, because I wouldn't have liked it if someone said that to me. So questioning your own behaviours is the biggest impact, I think, that it will have.
There was always that fear of, actually, could this end up in situations that could be confrontational? And it's not like that at all.
It's not to address things in an aggressive nature. It's very much trying to diffuse the situation. If you felt in danger, it's to take yourself out of that situation, check in on colleagues later. It's just responding appropriately in that moment.
It just feels very natural to me. And I think once people know that they have the strength and the organisation behind them, it will come naturally to them as well.
I think seeing that we'd got senior stakeholder involvement within the programme meant a huge amount, and it just shows that everybody's on board.
For it to work, we all have to adhere to civility. And civility is stuff that we've learned from a young age. Your moral compass should exist in both your work and your home life.
Because it's all about human relationships. You take it everywhere you go. You know, you use it in the supermarket, you use it at the bus stop. It's not something you ever switch off. Once you've learned it, it's with you.
So there was an incident in my local town, and there were some lads. They walked past and then took a second look at somebody that didn't conform to society. Very, very vocal, and verbally abused this person. And I actually spoke to them and I said, just leave this person alone. He does no harm to you. And my daughter actually said to me, I'm really proud of you, Mum, for doing that. And the Active Bystander Programme, I would not have done that before.
I think what the programme demonstrates is change starts with you, and that's really important. And I think as the programme goes on and more individuals are grouping together, exchanging their ideas, their stories, their experiences in the action learning sets, that really has a powerful impact.
The action learning sets are actually brilliant because it's a way of staying in touch with the active bystander community as a whole.
A lot of courses, you go on a course and that's all you do. These are about embedding the learning, and actually these can be quite tricky situations that colleagues find themselves in. So it's a safe space to build on that learning, share experiences and create that community of practice amongst the delegates to keep that momentum going.
We have regular follow-ups every month or so where we get to talk with our group and talk about the challenges we've had. And that shared learning has made it really valuable.
After nearly a year of us running the Active Bystander Programme, it is so important that we keep the momentum going. We need to stick together, help each other, and if we can do this, we can do just about anything.
As a sponsor, for UHL. I am so proud to see the number of staff that have already engaged, not only just on the programme, but to be also train the trainer. Thank you so much to all those staff members who have taken the time to attend the Bystander programme, to spread the word and make a difference.
From a leadership perspective, Active Bystander is one of the tools I've added to my toolkit, and it's one that I use. It makes people think, and it's when you think, that's when you learn.
Well, there's always at the back of everyone's mind a fear that it just won't work. But it's up to us to make it work. And through changing that with one person at a time, we will change the culture eventually.
The people coming out of school, going into work, wouldn't it be a nicer place if we'd already embedded this culture and they were coming into a place where you're spoken to nicely and you're treated in a manner that you'd want to be treated. And it also, the behaviours wear off on them. They start treating people that way. They start to embed those behaviours within them. And that's the change. That's the whole culture change. And that's why it's important everybody, every level, every department gets involved with the Bystander programme, because it's important, and it's important for the next generation.
The more staff members can go on this programme, the more knowledge and ability and awareness we've got in order to deal with situations.
We had a fantastic group, all different ages, diverse, different roles and responsibilities. I would recommend it to absolutely anyone. It's only going to be a positive thing.
It's going to grow organically, but it needs more and more people to come on and actually live and breathe it. I can already see the changes that the programme's making in people. Really, the only way to experience it is to come along and join yourself and see what it's all about.
I think it's such a great training course that I wanted to encourage lots of other people to go on it.
I hope you'll take the opportunity to join the Active Bystander programme and make a difference.
I'm really proud in terms of the feedback we're getting already in terms of the difference this is making. Colleagues are sharing with us that this is the best programme that they've actually accessed, that this is making a difference, and this is telling us it's the right thing and we need to continue on our journey.
Thank you very much, Fiona, for sharing that. Very inspiring work. And thanks for joining us today. Great to have your input. So we've got a few questions specifically for you. One is, how do we find out more? And can you share your slides? Obviously, this webinar will be on our website, which hopefully everybody has now. But yes, if you would be willing to share that, that would be great. And contact Fiona. I don't know, Fiona, if you're happy to put your contact details in the chat, and then people have got your email if they want to contact you directly. And Susie said, was that a day and a half training? I'd be interested if you received any resistance that amount of time, and if so, how you overcame it.
Do you want me to answer now or in the Q&A?
Yeah. No, answer now. This is the Q&A now. This is it. We're here. Thank you.
We did. And I'm coming from the transformation team within an acute trust. We were going to be launching in October, got lots of resistance. But interestingly, initially, we thought it should be a modular program over 3 months, half a day here and there. What we did was I did bring the material into a day and a half, and I said, actually, this is the space and the time that people need to cover everything, for them to have that real space to do the self-reflecting. And actually, what's happened is we tested it out, and the first lot of people we got were actually people I was knocking on doors, people I knew from across our system. And it was when they came back and told others about it, people are now saying, well, yeah, I acknowledge we need that day and a half, we need that space. So active bystanders are going back and saying we need that space, but fully recognize that we cannot release all our staff to do that. So there's definitely something around how we have our framework for a couple of champions who role model it, greater depth, if you like. And then the next layer down, which is awareness raising, speaking the same language, and also quite a lot of pushback, people saying, well, this could just be a mandatory training piece. everybody just needs to do it. It's mandatory training. And our learning so far has been that you need positive, those people on that innovation curve, the positive people at the front role modeling the great behaviours so that others might follow. So that's why we've not created a mandatory training element to it for everybody. But yes, we did receive some pushback. Nevertheless, we've had, for example, our pharmacy colleagues who were incredibly pressured as a team over that, sort of October to February time. They sent a lot of their staff on this because they felt it was making a difference. So I think there's something around proof of concept that helps. And it's just going back to well, what do we want the impact to be? Tick a box, or genuinely have some real improvement in culture change? And it's going to take 5 to 10 years. This is not going to change our system overnight, not with the volume of staff that we've got. But we're hoping it's going to incrementally start making a difference.
Thank you, Fiona. Are you happy for us to put your email in the chat to everyone? Thank you, Justin. Maybe you could help us with that. And another colleague, I think, wanted to know, could they get in contact to discuss a good case of good practice? So Dasha Ibrahim has said, get contact details, so we're going to do that. How can the programme be rolled out across all NHS organisations is the next question. How do you scale up?
That's the wicked problem. I mean, I can see Justin laughing as well. So that is, it is a really challenging and really important question. It's the what next? So we have been in conversation with our national colleagues about what that might look like. Bearing in mind that our ICB has really supported this, we do want to share what we've done. And so some of that may well be looking at different models of delivery, particularly if you're looking at ICSs, for example, so Leicester, Leicestershire and Rutland, we do have a diverse population and it is spread out in, rural, urban, but that's quite different from, say, for example, Cornwall. And bringing people together there would prove difficult in different ways or different challenges. And so those are the sorts of, when we're looking at this innovation, how we're going to spread, adopt and adapt it, I think there's still some more work to do there. We're not nearly there. We're kind of telling you about our pilots and how we've done with our small and a little bit of our learning, but there is still, we have a way to go.
Well, great to hear about it. And obviously, I think our audience have found it very inspiring. In terms of a little challenge there, in terms of we are researchers on this call, and I wonder, have you thought about writing up your pilot and publishing it so to get it more widely known? Is that something you're thinking of?
We have done, and I know we need to. So there's something around how we communicate. So up until this point, we're communicating through our usual health and social care channels. So I've spoke at the People Promise, was it last week or the week before for NHS England, and we are getting the word out that way. Absolutely. I think the other challenge is the material that we have. It would be great to publish. There's something around time and the practicalities that when you're thrown into the operational side of things, it's quite tricky. It was tricky enough to have me released to lead this and to start this. So I guess there's some of that as well. But yes, that is not off the cards. It's something we would love to do, to share.
Maybe you could create an online MOOC or an online resources for people to take and run with or something. But yeah, do you actually have a publication, or you've written it up, or not yet?
Not yet is the completely honest answer.
Fair enough. It is a pilot stage. Fair enough. But I guess, going back to where we started, and our encouragement to anybody who's done any work in this area to write it up, publish it in some way, because our sort of at the type of review we did, we looked at editorials, we looked at pieces in HSJ and other places and blogs. So it doesn't have to be academically published. Better if it could be, but we found so little in the NHS, and we know there's good things going on, but it'd be great to spread the word and see it evaluated and published. So encouragement to anyone doing work in this space to get it out there. There's a comment, a couple of comments about this would be great for undergraduate education. And you know, for developing our future leaders. Certainly at the University of Surrey, we've had a project going on called Melting the Snowy White Peaks, where we've been doing reverse mentoring and some active work to develop our Black, minority, ethnic students, and been decolonising the curriculum and trying to develop an active bystander programme. So I wholly agree with that. So any materials we can get from you to help us develop that would be much appreciated. And I know others on the webinar would appreciate that too. I don't know if you have any thoughts on that.
We did initially, so we have tested out part of our intercalated for our midwives. So we did test out a day's training with them. I did initially, because I used to do quality improvement on the intercalated course for our 3rd and 4th year med students at the University of Leicester med school. So that's not off, that is something to do as well. The challenge is when you don't have enough resource to do this, and that's possibly what you found with others. People might be doing good things in satellite areas. The challenge is that we don't have a comms team, we don't have all those other structures in place. And now that the civility and respect team have been restructured, even less opportunity to perhaps reach out to national colleagues for some support in that way. So yeah, and I think it's those ongoing conversations, and the more we get the support locally, the more we'll be able to do that, hopefully. But that is the next step, because you want your teams coming up through having that knowledge, particularly from a patient safety perspective for our nursing, midwifery and medical students.
Definitely. We just need to clone you a few times, Fiona, and send you out. Let me see, are there any other questions, comments? People saying it's a powerful programme, especially embedding follow-up sessions, building trust and creating a safe space. Thanks, Diana Bass. Heather Lane saying the training looks great, going to use a master's dissertation to capture more research on neurodiversion to increase awareness and promote equity. Equal representation at senior leadership level, support and promote a culture of authenticity, openness, awareness and transparency. And that was very notable, I think, from your programme, getting that buy-in, leadership buy-in. And Claire says it's a really good point you make about operational staff at the front line needing to have a job plan to enable stronger clinical leadership. So yeah, important reflections and comments there. So thank you so much, Fiona. Fabulous to have you join us. Thank you for the film. Thank you for the slides. We'd love to share all of that with everyone who on this webinar and people who signed up. So we will make sure we do that with your permission. Thank you. So that takes us into the last 10 minutes or so of our webinar today. Thank you for everyone who stayed the course and stayed with us. I don't know if anyone has any more questions or comments from the audience, or whether any of the project team would like to offer any further reflections or comments.
Can I say something while we're waiting for any final questions?
Please do, Justin, go ahead.
Yeah, I just wanted to say thanks so much to Fiona as well. We'll be in touch. I'm really impressed by the video. It's great to see such a well-produced video. I'm sure it wasn't easy getting the budget for that from the sounds of things. But it was really good to see some of the real people who had been through that program and to see the impact that it had. And it's, I think, encouraging for everyone to see that these things are happening even in such a resource constraint environment. And I'll be in touch. Yeah,
definitely. Thank you, Justin. Thank you. Yes, so our next steps are cutting the ribbon on our new website today, which should now be open. This webinar will go up on there. The guide is on there. Please disseminate widely. Please tell us if you find it useful. Please let us know where you've sent it and if anybody is using it. As many of you will know, we have to kind of capture and measure impact as academics, and that's not always easy. I've got a long list of people we need to send it to, including the CQC, the NMC, and the Royal Colleges. So we've got much work to do for continued dissemination. So yes, thank you for your time. Unless anyone on the project team wishes to say anything, thank you, Joanna, for joining us from Australia and for talking about the Ethos programme. Really great to hear that work going on in practice. And Russell and Alid and Judy and Mark and Ruth and everyone joining us. So thank you very much. So if there's nothing further, oh, Joanna, did you want to say something?
I just wanted to thank you, well, the whole project team, but particularly thank Jill for your incredible leadership from this program. It's been a real delight for me to be able to join with you all in participating, and I'm very proud to be associated with this piece of work.
Thank you, thank you, thank you. And yeah, it's been a big piece of work, and thanks to Justin for all his efforts sifting through all that literature and reviewing it all, a mammoth task. But also I think we've all had a big learning curve about making the guide and the illustrations and the website, and it's not necessarily our comfort zone as academics. So we've tried to make it practical and accessible, and hopefully everybody on the call feels that that's the case and can use it widely. Just a plug for our next webinar, which will be on December the 7th. We will send, with your permission, an invitation to that to anyone on this webinar, which is about care under pressure too. So building on the staff wellbeing issue, looking at poor psychological health in nurses, midwives and paramedics that I've led with Kath Taylor, and we're producing another guide. So join us then if you can, and look out for that. And without further ado, we'll give you the whole gift of 4 minutes back. Thank you for staying the course and 2.5 hours with us. And thank you so much for your engagement and for joining us today, and have a good rest of the day. Thanks very much. Bye-bye, everyone.